Hey, good evening, everyone. I think we're going to go ahead and officially get underway.
Smartphone connected.
All right. First thing I would like to do is acknowledge that we are conducting this meeting on land that is historically belongs to the Duwamish tribe. And really just put out some energy to appreciate how well they took care of it for us and think about how we can continue to do our best to take care of it too. So thank you for that. Also, we have a really good meeting to get to here. We're very excited. Let's see. We're going to go through the agenda first. But first I really do want to talk about, because this is a big meeting, this is really going to pave the way for 2020. But I did want to talk about, we did do some really good stuff in 2019, and we're really excited to be a part of that. It really does remain that we want affordable health care right now. As we look ahead to 2020, a lot of the stuff we have on the agenda is all about making healthcare more affordable and more accessible. And we want to be able to health justice movement that connects the great work being done at the state, federal, and county, local levels to make sure that affordable healthcare and healthcare in general is a central issue in 2020. So yeah, thank you all for being here, and let's continue to build healthcare as a human right. We did get 20 new organizations signing up as allies or sponsors in 2019, so we are growing. And we're really excited for all of you who have stepped up and done more and really put in the work on the committees and whatnot. So thank you all for all of that. So going through the agenda really quick, I just want to let everybody know what's going on with that. We're going to do a quick round of introductions for the remaining sponsor organizations that have a vote tonight. We're going to make sure that as they get in, they'll get their cards. We'll do intros, and then we're going to explain the deeper parts of what we're all voting on. Just as a heads up, we feel like we've come up with a pretty good plan here for voting through everything. We're going to propose to vote as much of it through as a block as possible. So we'll explain everything that we're voting on. And if anybody wants to remove one or two things in order to vote it through as a block, we can do that. And then after we're done voting, we're going to have Margaret Carey is here. She's on our steering committee. You had your hat on. It really threw me off. She's not over there. She's going to go through a lot of the stuff we talked about at the end of the last meeting, and then right before we start with intros, I want to bring attention to these sign-in sheets that we're going to pass around, one in each direction. These are for organizations. Please sign in. Please check the boxes on the right if you're interested in connecting with our communications committee, organizing committee, or policy committee, and also if you're interested in working on state or federal issues. Now, the policy committee and the communications committee are where we need the most help. And speaking from that, I want to thank Bevan and Nicole Gomez, who have been co-chairing that committee. They've done a lot of really great work, but at the same time, policy is it's a heavy lift, and they're doing a great job. But we could always use more help there. And speaking of committee participation, that is one of the ways. It's not too late. If you are still not a sponsor organization, it's not too late to sign up right now if you can make a financial commitment to healthcare as a human right, or if you can make a commitment to participate and share in the work. And defining that, just be really clear, be a regular member of one of our committees, whether it's organizing, policy, or communications. So if all of that is clear enough, we're going to go ahead and do a quick round of intros. And because we're free thinkers here, we move to the left.
David Loud, I represent Puget Sound Advocates for Retirement Action in Healthcare is Human Right. And Nathan and I are at the moment co-chair of the steering committee. He, him.
Eric Gonzalez Alfaro, he, him, the legislative director for the ACLU of Washington.
Margaret Carey, Seattle Indivisible, as well as Working Families Party, she, her.
Katie Young, North Seattle Progressives, she, her.
Kelly Powers, Healthcare for All Washington, she, her.
Marsha Stedman, Healthcare for All Washington, she, her.
Jim Howe from newly allied American Federation of Teachers, he, him.
Susan Eidenschenk, League of Women Voters, she, her.
Kim Abbey, League of Women Voters, she, her.
And Latanya Lester, Health Policy Director at Children's Alliance, she, her.
Marina Koshi, Washington, Protect Our Patients, she, her.
Vanessa Molson, representing Mary Mahoney, and I'm a PSAR member. And I'm going to, on behalf of Raleigh Watts, who is chair or director of Country Doctor, is not able to be here or by phone either, and I will be his alternative representative for voting.
Could you hold the microphone for me, please?
My name is Joe St. Alpin, and I'm just an interested person.
I want to invite everybody on Zoom. I want to thank you for joining us and invite you to now introduce yourselves.
David McClanahan, I'm operating the Zoom and the camera at the same time, so.
Sherry Weinberg, Physicians for National Program, Western Washington.
Jane Sis, Faith Action Network. Kathleen Randall, Physicians for National Health Program and United for Single Payer, and North Seattle Progressives.
Larry Cole, North Seattle Progressives.
Pam Dolan, North Seattle Progressives.
Chris Olin, North Seattle Progressives.
Catherine Lewandowski, Whole Washington and One Payer States.
Rachel Ursud, SEIU 1199 Northwest.
Sybil Hibley, Washington State Labor Council.
Sam Hatzendealer, Economic Opportunity Institute, and she, her.
Steve Bach, Puget Sound Advocates for Retirement Action, he, him.
Mike Andrew, he, him, private work.
I'm Eugene May from Washington Protect Our Patients and National MS Society.
Seth Greiner, National Multiple Sclerosis Society, Northwest Chapter.
Nicole Gomez, Alliance for a Healthy Washington. Bennett McLeod, Alliance for a Healthy Washington, she, her.
I didn't actually introduce myself. Nathan Rodkey, Washington Can, he, him, and I also co-chair the Healthcare is a Human Right Steering Committee and Organizing Committee with David. For now, I'm going to hand it off to my right here to Bevan and Nicole, and they are going to do a very brief presentation of the policy proposals that we put forth. The reason these are up for a vote is they were brought to either the steering committee or primarily the policy committee. So we're gonna go through those briefly. For organizations that are sponsor organizations, you should have a voting card. If you don't, make sure you get one. And yeah, for those of you who do not have a voting card and cannot vote, you are still welcome to join the discussion if you have anything you want to speak to any of the proposals, why you would or would not support them. We do welcome that discussion. So yeah, feel free to be heard and called on and then heard. And yeah, that's about all I have before I hand it off. So.
Hey everyone, so I wanted to talk a little bit about the goals that were guiding our work.
The first one being to make progress towards universal health care in Washington State and our nation, to improve affordability of healthcare, achieve racial equity and overcome disparities, and then also to protect what we have now. Those are our guiding principles when we were working on the policy committee. The policy committee had originally come up with, I think, 5 state items and then 2 national, but we decided to work with the steering committee, and they also had some suggestions from people in the room. So that being said, I'll go ahead and go on to the federal policy, and then Evan will talk about state. So the first one was the National Single Payer Improved Medicare for All. That's HR 1384 and S 1129. It was in the House. It's Representative Jaya Paul is a sponsor, and in the Senate, it's Senator Sanders. Currently, the bill in March, there was just on the House side was an introductory remarks that were made, and then in the Senate it was read twice and referred to the Committee on Finance. Basically, what it does is it establishes a national health insurance program administered by the Department of Health and Human Services. It should cover all U.S. residents, provide automatic enrollment of individuals upon birth or U.S. residency, cover items and services medically necessary to diagnose, treat, or rehabilitate a health condition, and that includes hospital services, prescription drugs, mental health and substance abuse treatment, dental and vision services, and long-term care. It prohibits cost sharing, which is like deductibles, co-insurance, co-payments. And then it does not affect coverage provided through the Department of Veterans Affairs or Indian Health Services. So that's kind of just a real brief overview of what it does. Individuals who are age 18 years or younger and age 55 or older who are already enrolled in Medicare can enroll in the program starting a year after it would be enacted, and then other individuals would buy into the program at that time, and then it would be fully implemented within 2 years. The next item on the list was to consider other proposals that lead towards universality. Sorry, that's loud. And that one is just a general idea because of the Healthcare as a Human Right campaign support of progress towards universal healthcare. They feel it's important to leave the door open to pursue other legislation as it's introduced that has that goal in mind. The next one is State-Based Universal Healthcare Act, and that's HR 5010. It's introduced by Representative Rokana of California on November 8th of this year, and it was referred to the Committee on Energy and Commerce, and also in addition to the Committees on Ways and Means, Oversight and Reform, Armed Services, and Education of Labor. Let's see, and that should be the period is subsequently determined by the Speaker, and in each case for consideration of such provisions as they fall within the jurisdiction of the committees concerned. The bill itself, the official summary is not available, but I took a look at the bill. It amends Title I of the Patient Protection and Affordable Care Act to authorize the establishment and to provide support for state-based universal healthcare systems that provide comprehensive benefits to state residents and for other purposes. It's basically establishing a framework under which states can provide comprehensive universal health coverage for the residents, and then Subtitle D of Title I of the Patient Protection and Affordable Care Act is amended to, after Section 1334, to include a new section, Section 1335, which states waiver for state universal health care. The next one is lower prescription costs for consumers. And that one is an overarching goal, again, to improve affordability of healthcare. And again, as legislation is introduced, Healthcare as a Human Right campaign would like to support it, or at least propose it to be supported. Let's see, and then again, if there's a proposal out there that we find out about that doesn't meet that goal, then also potentially oppose it. An example of something like that that I found was today, HR-3, the Lower Drug Costs Act of 2019. That was passed in the House, and it was sponsored by Representative Frank Pallone of New Jersey. And that one is probably not going to pass in the Senate, but that's an example of a bill that we should be watching for. The last one on the federal side is to defend existing programs. So I know there's a list here on the agenda that explains that and further. And again, it's the same idea of just protecting the things that we already have unless it's replaced with something equal or better.
Thank you, Nikki. Obviously a lot to go through. So at the state level, we're looking at universal, sustainable, and affordable healthcare for all Washington residents, and what kinds of policies we can support and look at that help us get there or are directly working on that particular issue. At the state level, Healthcare is a Human Right campaign would like to continue to message to this end and to make sure that we let folks know that this is what we're really working towards. And we want to monitor the progress of the Pathway to Universal Healthcare Workgroup, which has recommendations due to the legislature in November of 2020. And a few of us are actually sitting on that committee together, so we'll be happy to talk about it.
Raise their hands so we can see who's on the work group. Hey, Sybil, you're on the work group?
As reports come out, and the Healthcare Authority will be sharing those, but we would be happy to do so as well with the folks in the room. Also looking towards some sort of program for our undocumented populations. NOLA, and I don't see Janet here tonight, but I know that NOLA and Representative Macri are working on something. I don't have any bill language, and I'm not sure if anybody else in the room does. Do you, Eric? Do you know of what's?
Not specifically that one. I think it kind of relates to the work that King County has done and kind of making sure that there are options for undocumented folks to get covered.
Yeah, and I'm hearing that King County is trying to push the ball down to the legislature. So anyway, we want to continue to monitor that and see if anything comes forward for the session that we can help support in that vein. Strengthen Apple Health, Washington Medicaid, including healthcare up to age 26 for undocumented populations. So that was a bill that was proposed in 2019, SB 5814 and HB 1697. So we're hoping to see that make some more progress this year. I'm not sure yet what that's going to look like. I tried to find a fiscal note for it and I couldn't find it, so I'm not sure if the work has been done there, but that would be the only reason that I would see that wouldn't make it through. As we all know, we're kind of hamstrung in terms of funding at the state level. But that, let's see, so it made it to the Healthcare and Wellness Committee and the Senate Health and Long-Term Care. It's still a live bill, and so we just want to continue to push on that. So it requires the state healthcare authority to provide health coverage to individuals who are between the ages of 19 and 26, have a countable income that is at or below 133% of FPL, are not incarcerated, and are not eligible for categorically needy medical assistance as defined in the Social Security Title 11 state plan. Requires the authority to seek federal funding to defray state costs associated with providing coverage to those persons. So that would be the other piece I think that would be tricky, is getting those federal funds into help. We're also looking to support dental therapists. There's two different bills there, HB 1317 and SB 5392, also carryovers from 2019. Really, this is looking to increase access, especially for adult Medicaid recipients, because as dental therapists, they're would be under these bills, allowed to be seen as a profession in Washington State and would be able to work in community health centers at a much reduced cost to normal dental care, and they can do the primary care dental work. So they don't do everything that dentists and orthodontists do, but they provide the necessary care so that folks can get their x-rays and they can get their cleanings and so on.
I'm looking at increased pregnancy care to 1 year. Right now it's two months, and so it's looking to extend it to 1 year. That should be a standalone item. But it is a part of a sort of a package of bills that the ACLU and OLA is pushing that includes mental health, expansion to age 26. So it's kind of a package, but they're separate bills. But this would target undocumented communities, and about 17,000 undocumented folks would benefit from that expansion. The fiscal notes are about $24 million, but we're looking at possibly doing some sort of phase-in to sort of address the fact that the public charge at the national level might have a chilling effect on the amount of folks that want to enroll. So maybe looking at 10,000 slots the first year, reducing the fiscal note down by half, and then asking for another 10,000 for the following biennium. So I think the other thing too is that it's scalable. So while it is 138% of the federal poverty line, that can go up. And that's also another strategy to cover everyone.
Thank you for pulling that out, because the notes on my computer are slightly different than what's on the page. So yeah, that's definitely something that we want to look at. And thank you for the update on that, because I hadn't heard yet where we were with that. Okay, so supporting the dental therapist, that's really, the big push for me on that, as we look to try and get to universal, where we can actually have dental care for everybody. This is a step that our state can take to improve access, especially for adult Medicaid recipients. Lower prescription drug costs for consumers. I know that there have been conversations. We did pass the bill last year that is basically asking for transparency in drug costs at the state level. It doesn't go quite far enough, and there's some really interesting legal reasons that states can't mandate that drug companies, set their prices at certain levels, but there's still things we can do, I think, that can be helpful. And I know that there are conversations about specific drugs, such as insulin and other top generic drugs in the state of Washington, that we can look to bring the cost down on. So staying on top of that, and what kind of bill language might come out as well. And let's see, we're monitoring the work to implement Cascade Care. So the Washington Health Benefit Exchange is working to implement Cascade Care in partnership with the Healthcare Authority and Office of the OIC, the Office of the Insurance Commissioner. And so the implementation includes standard plans. So standard plans, which are qualified health plans that have a standard benefit design across carriers, will be more understandable, more affordable, and of more value to Washington Health Plan Finder customers. The public option plans, so the Healthcare Authority will be working with the exchange and other implementation partners to procure public option plans that will be available to Washington Health Plan Finder. Public option plans are qualified health plans that have a standard benefit design and meet additional quality and value requirements. And then there's a subsidy study as well, looking at potentially a premium wrap to help folks fill the gap on that. And I'm sure once we open it up for discussion, I know there's some people in the room who are working on that. So, I'm personally not, on any of those committees, so it'd be nice to hear from folks on how that's going. And then establish a state office of equity to promote access to opportunities and resources that reduce disparities, including racial and ethnic disparities, and improve outcomes statewide across all sectors of government. And am I right that that's a pre-filed bill? Or no? I guess it's a carryover. Creating the Washington State Office of Equity establishes a task force to develop the initial operations plan for the Equity Office, requires all state agencies to provide appropriate and reasonable assistance to the Equity Office as needed, work to meet the established performance measures, and implement equity assessment tools as appropriate. And then we have the Protect Our Patients Care Act, to prevent health entities from interfering with a qualified health practitioner's ability to provide their patients with medically accurate and comprehensive information and resources, and in cases where there is a serious risk to patients' life or health services. And that one's sponsored by Representative Macri and Senator Cooter. And so that kind of sums up the state stuff that we're looking at the moment, that both the steering committee and the policy committee had kind of put forward as proposals. And we are also looking at local policy advocacy, which was the King County proposal that came through a budget proviso that several folks, including Teresa Mosqueda and Rod Dembowski were working on together to hopefully create a county-based plan that would offer coverage to the undocumented population in King County and be able to kind of expand from there. They've run into a funding issue, and so I think they're trying to kick the can down the road to Olympia. So we'll be monitoring that process and how things are going there, but want to make sure that we're offering support where it's needed in getting that done. I think, it could be a very interesting incubation model that we could expand statewide, potentially, so making sure that we're staying track on all of those things. So I think at this point we wanted to open it up for discussion, right? So anybody who has any questions or wants to discuss, I think the idea is to take these proposed items and we would love to see them voted through as a slate, but if there are particular ones that folks want to discuss or pull out, now is the time to do so.
Regarding the State-Based Universal Health Care Act, HR 5010, I just wanted to point out that in front of you is, in fact, a summary that came from Representative Khanna's office. It's not the official congressional summary, but it is the summary that he provided to us and some frequently asked questions. The other thing I just want to say about it is that it is being championed by the leading champions of Medicare for All in the Congress. It's not an alternative or a competing proposal. It's a second track of a strategy to achieve Medicare for All. The idea being some states are closer politically to creating universal systems than the federal government is, but many of us believe states could not do so without a lot of support from the feds that is not available now, particularly getting the federal health care dollars, Medicare, Medicaid, CHIP, TRICARE, federal employee health benefits, and so forth, to be able to use in the state to create a universal plan, and an additional provision in there, which is quite interesting, which is the so-called ERISA waiver. ERISA is the 1974 law that protects retiree benefits, but self-insured employers have learned how to use it as a weapon to not participate in any mandates from the state on benefits, healthcare, retirement, or anything like that. So an ERISA waiver would be required if you were really going to bring all the self-insured employers, and most of the big companies in this state and the country are self-insured, to bring them into a state plan. Anyway, I just want to say that the information is in fact there, and it's part of the dual strategy that is being pursued for Medicare for All. And regarding the work group, the Universal Healthcare Work Group that we helped bring to life, and that some of the folks here are on, it's sort of like, okay, how could we do it? Well, this is one pathway to universal health care in Washington State that may be available if we get that passed through Congress.
My comment is a little more general. It sort of is involved in several things here. I think it's really important to understand that just being insured is not enough. That you have to be insured with a plan that adequately protects you against high bills. And one of the current dodges that's used a lot is high deductible, they keep the premium down, but there are high deductibles and high co-pays and high co-insurance that may mean that somebody's insured but they can't afford to use it. So we all know that, but I don't quite know how to put that in here, but it's something we really need to be aware of when we're evaluating things like other proposals that lead toward universality, etc.
Well, it's really avoid underinsurance.
Maybe it's something to piggyback on what you're saying, Sherry. It's getting at maybe no networks, no co-pays, no co-insurance. Stopping that whole system because it's just a game of whack-a-mole.
I wondered about dental therapists, is that what it's called? I actually wasn't familiar with that term, so I pulled up the bill. And I couldn't see anything in there that was different from what I think dentists can do. Number one, that's the first question. What is it that they would not be able to do that dentists can do? And second, I couldn't see anything in there about licensing, whereas the other, in the sort of introduction of the bill, it talked about other kinds of dental age, hygienists, etc., and it indicated some crossover to licensing standards, but I didn't see anything like that for dental therapists. So I wondered, is there such a thing, or would this be piggybacking on what Alaska does, or what?
Thank you very much.
Can I just respond to that, because
Sure.
I looked that bill up too, and I did find a place, I don't know if I copied it or not. Oh, it's here. Dental, here it's in section 6.
Right.
And it says dental therapists can only practice under the supervision of a dentist licensed under chapter 18.34 of the RCW.
But as far as what they may do, I couldn't see anything that...
I'm going to get that question answered for you right now. I could kind of answer it, but Washington Candidate is a part of that work, but we're working with the Children's Alliance, and I do want to open the space for LaTanya from the Children's Alliance, because she is deeper on it than I am.
Hi. Yeah, thank you for raising the question. So I actually can't name the specific scope of practice of a dentist, but I know that the scope of practice for a dental therapist is around 50 procedures, whereas the scope for a dentist is something more like 500. So it's a much more limited scope. And the path to licensure is this Commission on DQAC, Commission on Dental Accreditation, which also sets accreditation standards for hygiene and dentistry, has a set of accreditation standards for dental therapists that's already set. And so their path to licensure would be part of going through an accredited program, graduating from the program. I'm not sure if the bill stipulates if there's a specific exam or if it's just graduating from an accredited program.
I didn't even see that, but if you think it's in there, I believe you. But is that a national or a state-based commission?
Yeah, so, sorry, I actually quoted the wrong commission. So CODA, the Commission on Dental Accreditation, is the national body that sets standards, and they have set standards for dental therapy. DQAC, which is our state board, sets the licensure standards for the state. So there is a path that's set up in the bill for licensure, and also names the specific items that are in the scope of practice for the dental therapist. I would say that so dental therapy education is 3 academic years, 2 calendar years. And the intention is to have a provider in dentistry that's a mid-level provider who can come from communities that are currently underserved when it comes to dentistry. And that is with the goal of having providers who are from the community, have cultural understanding, linguistic skills that meet the needs of the community and can really address existing barriers that aren't just about coverage, but are also about the other barriers to care. Fear of the provider, having really negative experiences with providers who aren't from the community, aren't connected to the community. So that's one of the main tenets of the provider and why it's been so successful in Alaska. I could clearly go on for a long time, and I'm happy to answer any additional questions.
I I was interested in a little bit of discussion around monitor work to implement Cascade care. I was interested in finding out a little bit about what that means. Like, what influence do we have over that? What kind of leverage do we have? I wasn't sure what that item meant. And I also wanted to piggyback a little bit on consider other proposals. I wonder if we want, we don't have to have this nailed down, like down to the nitty gritty, but I'm wondering if what's making us uncomfortable with that is that we really are worried about, not getting close as far, advancing the ball as far as we want, or getting the key things that are part of our mission statement. I think we want to add language to that makes it really clear what we mean by universality, and we're talking about advocating, not just considering. Those are the two things that popped out for me, that they were written in a vague way that gave me that feeling like, I don't know, what am I agreeing to here? That doesn't feel like it's got enough teeth in it, or it doesn't feel like we're really leveraging where we could have leverage. So I just wanted a little clarification on those two items.
Cascade care. Is there anyone here in the room who's part of the monitoring effort?
Yeah, what does that mean? Well, I went yesterday.
Okay.
Let's hear about it.
Kelly can give you a good example.
I went to the Joint Select Committee on Healthcare
Oversight.
That's right. And it was really fascinating. They, Cody was kind of stunned because
Representative
Representative Cody was stunned because they were proposing only using 5 of the 3 collaborative procedures as they start the program, and there's a lot of procedures. That means they're not going to do a lot of procedures, and it turned out, this is where I was stunned and my jaw dropped. They don't have, they weren't given staffing money to create standard plans. So they're having to, I don't know how they're doing that, but they're doing it. But they're making a lot of noises that this is hard and we're struggling noises. And then the other thing was, Representative Cody said, well, hey, this should be pretty easy for you to do the free collaborative because you're doing it for Medicaid already. And then they informed her that, no, actually we're not. And then she literally had like steam coming out of her head. So interesting things going on in that work group. And I think there is very much a lot to look at. Their scenario, their initial work shows that a bronze plan would save you 0.08% on your premium. And then the premiums would increase for the silver and gold levels, but it would be offset by not having, it's the whack-a-mole again, and you wouldn't have quite as much sharing. The patient would potentially save some money. So for example, somebody who had to get blood draws every week, the scenario that they used, they would save $500 a year through Cascade care. So I think there's a lot of work to do there.
So what does that mean for monitoring that? What can this group do? I guess is kind of what I'm wondering.
So I guess basically the monitoring portion of it is to go to the hearings just like that. There's also a public comment periods that happen occasionally, so it's also making sure that someone is at the public comments providing feedback from things that we've been learning about it and from things that they've been posting on the website, wherever else. And then also if there's missing pieces, also taking an eye on what could be done in the future to help fill those pieces. And then as far as the universality, I don't know if David talked about that one.
It's on CBW too.
And on Cascade, one more point, which is that Janet Varon, who is the executive director of Northwest Health Law Advocates, which is a sponsor organization, and she's been with our effort for a long time, couldn't be here tonight even by phone. She is, and help me here anybody, she is, as I understand it, a member of a work group that was formally convened to monitor the implementation of Cascade Care. Is that the same work group that you went to a meeting of? I didn't think so.
This was legislative.
Right. So there.
Some of those people on it.
And can anybody else shed light on the work group?
Yeah, there's a bunch more people on it.
Yeah.
Okay.
Who would like to take this? All right.
I guess I can. I've been at 2 meetings so far, but so let's see. Which question should I answer? So yeah, there's the standard plan development work group, and
that is finalized, but there is a public comment period December and January, so we can send that out for people to give their input. The gold and silver plans are actually much more robust, and there was a lot of work done to reduce the co-insurance, and that to try to prefer co-payments instead of co-insurance to keep the costs more so people would know what they're expecting to pay. There's concern over what the premiums are going to end up being, so we don't know that yet. What else?
There's also going to, thank you. So there's a standard plan work group, which Sam just mentioned, which just wrapped up. And what was being alluded to earlier was that the healthcare authority has to design and procure the standard plan, so they have to do the negotiation to figure out who will be able to provide the standard plans and all of that. And I think that's what they're having some consternation about. They have a pretty tight turnaround to wrap that up. But the standard plans that our work group recommended and helped design will be online in 2021. And then after that will come the public option plans. And one thing I wanted to emphasize with that's important is that there are cost controls in the public option plans, which is unusual and really critical for any of the work we're trying to do to expand coverage, where there is a rate cap for what providers and insurers can negotiate for healthcare prices, which is really important. So that is a huge victory for Cascade Care and really critical.
And it's like 100 and...
Yeah.
See, I think the idea there is we want to leave the door open for things that seem to get legs in Congress that really would move in the right direction. I'll give you one example, and I'm not up to date on this, but there's a bill that I believe is HR-1277, which is the state public option, not to be confused with the Medicare for All lookalikes. The state public option would create an opening for people to get covered by Medicaid who otherwise are not able to be covered any other way. And an interesting thing about it is that Dr. Kim Schreier, our representative from the 8th District, who has not yet embraced Medicare for All, she's on that bill. She really likes that bill. There are a lot of people on it. Guess who else is on that bill? Pramila Jayapal. Why? As I understand it, not speaking for her, but the way I understand it, is if you drastically expand coverage through Medicaid in the states, Medicare for All, if that gets enacted, actually eliminates Medicaid. So it's a step to build a publicly funded plan that expands coverage and moves toward universality. And so I think that the judgment we have to exercise as we look at things that come up is, does it actually move us in the right direction, or is it a Band-Aid that is sort of a standalone? And so anyway, that's just one example. So I think we wanted, the great news is that all of this stuff is at the center of the national debate.
Absolutely.
Right? I mean, think of how much progress that represents. So in this year, when there's going to be all this furious politicking about healthcare, there's going to be a lot of things proposed. A lot have been already. So we just want to leave the door open to see what happens and decide if there are things that we want to get behind.
I'm not suggesting that we close the door by any stretch of the imagination. I just wanted to kind of understand what that meant and how this group might engage in that work and that discussion.
Right here in some of the materials we offer to hand out, signing up for healthcare as a human right, I would offer you all this. Anything in terms of like monitoring and anything like that, it would be consistent.
Yes.
You can be confident that it is consistent with our campaign structure, which I will just read to you as follows. In order to achieve state and national healthcare systems, it will take a committed strategy of grassroots organizing and coalition building from a broad base of labor partners, community organizations, and advocacy organizations. And it would be towards universal coverage that's affordable. And if you basically everything that we put in our materials
Yes.
is consistent with that. We're going to be entering into that space with that in mind. So if it feels vague, just understand that we're always entering those spaces with that in mind.
I think one of my concerns has to do with, we're trying to grow this committee and this organization, and we're trying to put forth, we know, 2 really clean bills. One in the state that has to do with universal coverage for Washingtonians, and one federally for everybody in the United States. But there are so many peripheral bills, and we're spending a great deal of time, energy, and money dealing with all of those periphery bills. I do understand we want to build a platform towards it, but I think some things are just sucking energy out of our forward motion, and I'm a little concerned about that, and I just wonder what others think.
I can speak to that for a moment. Working with Washington Can, we got 44,000 members. I've spoken with maybe more of them than anybody, except maybe like Craig Jones or Kevin Elliott. And it would be a disservice for especially anyone that tells me that if they say, is there something that you can do right now that you feel like moves towards Medicare for all, but also we'll deal with my affordability issue right now, we're going to move on it. Because it's really important to take any step we can to make healthcare more affordable for people and more accessible. And every step that you take, usually, I mean, pretty much every single time that's going to mean involvement of both communities, but also government. And the more that it becomes part of an intertwined system that is that's something people expect as a right, it's so much harder to take that away from people once they have it. So the more that we're entering into the system for people to expect as a given is going to be a step towards Medicare for all. So that would be my answer to that.
Well, I'm in the camp, and I think several other people here are also, in that any step we take, I think, should not reinforce the for-profit private insurance companies that are the basis of our system now. So I don't think I like Cascade Care because the private insurance companies are administering it. It's called the public option, which, people think that's positive. A lot of people do anyway. But it's not really public because it's, you gotta run through your private insurance company to get your benefits. If that Cascade Care were run by an operation within the health authority or something within Olympia, then I'd be much more favorable for it, because I think that might be a step towards where we want to go, eliminating private insurance. So,
a couple comments on regarding the state-based Universal Health Care Act, and if you are going to be advocates for that, then I would also ask for you to be advocates for Hope Washington's bill that we worked so hard for. Also, if you consider yourself a grassroots community organization, that bill was put together at the grassroots level with a lot of hard work from grassroots people raising money to get the funding study. And, we didn't get enough signatures to put it on the ballot, but we didn't stop there. We had the support of a very supportive senator in our state senator who had us take it to the Department of Revenue, and they looked at it, they loved it. They realized how much money it's going to save the state of Washington. They put in a lot of language in order for them to be able to actually implement and collect the health care premiums that they would need to collect to implement it. And we can save our state money. So if you truly are in support of the state-based Universal Health Care Act, I would ask that you would also support Senate Bill 5222 in your policy, please. Thank you very much.
We talked about being accessible and affordable, but it also needs to be progressive as well. And I have mentioned this before in the policy committee. Unfortunately, I wasn't able to put much energy and effort into it like I should have. But what really needs to happen for disabled people that get their funding for caregivers through the state Medicaid program is that as it currently is right now, what happens is that DSHS contracts with agencies that home health care agencies that will provide caregivers. Unfortunately, these caregivers, although they do have some type of minimal healthcare training, are woefully inadequate to provide the services that they provide. And what really needs to happen on that level is to open it up where the disabled person can choose the home health care agency that they need that would provide those needs, much like a person chooses one's own doctor. And so that's on the for people that want to be able to maintain their independence in their home. The other one is in regards to long-term care, is that people that are in long-term care, some of them, due to health care reasons, need to be able to be, quite frankly, be able to allow the option of choosing a private room instead of always being shared with a roommate. That just doesn't always work out. And also, it needs to be financially adapted, where it's not sucking most of the person's income, leaving them only about $60 or $80 a month for them to spend on their needs.
Joe, I'm wondering are you asking us to add that as something that we might monitor and track and advocate for those types of actions to support the disabled population? Are you asking us to add something to our state or federal policies in that regard?
That is correct. Thank you.
I just wanted to let Joe know that on Tuesday at the DJ Wilson Rewire Conference, I heard from Representative Macri and a different representative, anyway, that they are looking at long-term care proposals, and so we'll just stay up to date, and I think, in line with the language that we have here is to keep our eyes open. So certainly we can, as soon as any language comes through, we can send it out to the group for approval.
Oh, that's great. Thank you.
All right. So I am going to pass it along to David Loud, and he is going to help. He and Marcia are going to conduct the voting process. Thank you very much for this discussion. And go ahead, David.
Okay. The first thing I wanted to say is that we are recommending voting on this whole set of proposals as a package. But we need to ask, is there anyone who wants to pull out any one of these proposals, federal, state, local, to be voted separately? And actually, she may not have been able to get on the phone yet, but Jackie Boschak, who represents two organizations in healthcare as human right, the Washington State Alliance for Retired Americans and the Boeing Machinists Retiree Club, both. She's at a board meeting down at Green River College, and she's head of the board now, and thought she would be with us. And if she were on the line, is she?
Yes.
Oh, great. So Jackie, this is your moment if you want to speak up about pulling anything out from the package to vote separately.
Well, thank you, David. The National Alliance for Retired Americans has not taken a position on any universal health care bill, and they have also not taken a position on the state-based Universal Health Care Act. And as the president of the Alliance, we are not supposed to take any position on a federal bill unless the National Alliance has endorsed them. So in that regard, I would like to take those two federal bills specifically voted on separate so that I can abstain on those two and then vote in favor of the rest of them.
One more question, Jackie. Would you like those pulled out together or one by one?
Unless anyone else has an objection, I would like to take them both at the same time.
All right. So now what's in front of us is a vote on two of the federal proposals. The first line there, National Single Payer Improved Medicare for All, and State-Based Universal Health Care Act. So those two are what we will vote on now. We have two vote counters, Seth and Marcia.
Yes.
And if you would be very careful to take the count, note it on your sheet, and then announce it and see if you're in agreement.
Now we're voting, what are we voting for, David?
We are now voting on two federal proposals together. National Single Payer, Improved Medicare for All, and second, the State-Based Universal Health Care Act. And you'll have the chance to vote yes, no, or abstain. All in favor of those two proposals, raise your vote card.
I'm raising my card, Sharon from UAW on Zoom.
Sharon, we got you. All right.
Sharon Crowley
got us.
Sharon Crowley from UAW 4121, which is the graduate students and postdocs union at the University of Washington. Thank you, Sharon.
A welcome late arrival. Thank you.
No, she
And
didn't.
I should say that I'm voting yes on behalf of Machinist District 751.
All right.
On behalf of what?
Machinist District
751.
Oh, right. That's Jackie wearing her other hat.
The yeses are confirmed at 18. Oh, good.
All right, now, any no votes? Okay, any abstentions?
Yes, on behalf of the Washington State Alliance for Retired Americans. I abstain.
So noted. All right, so now, all in favor of the motion to adopt all the remaining proposals that have not yet been voted on this page, indicate by your card and your voice.
Sharon from the UAW again, voting yes.
And Jackie Bashar voting yes twice.
So that's three, that's three on the phone.
Okay.
I've got 18.
Yeah, me too.
All right.
Should ask for no's.
You put your hand up for no. We'll call for the no's now.
Right.
Yeah.
Any no votes?
All right, we have one.
Any abstentions? Great.
All right.
So now we move to the next item on the agenda. Thank you very much, by the way. I thought this was very helpful and supportive too.
Yeah. So now it is time for me to hand it off to Margaret. She has an awesome presentation on. Stay with me, Margaret. Here.
Well, this is meant to be very quick. And so at our last meeting, how many of you were here for the small groups? We had a discussion. Okay, maybe half of us. So we had two questions that we dealt with in there were 6 small groups. The first question was, what issues are people excited about working on? and how do they relate to race and equity issues? The second question was what groups or impacted people should be in the room who are not here? And I'm not going to repeat everything that was said in each small group. I think the comments afterwards and the feedback we got at the end of the meeting and between meetings were that was a great way to engage with each other because it was a smaller venue. And we had some really good discussion about Medicare for All, universal health care, why that is important and is very much connected with our system, which generally provides lack of access for overall people of color, immigrants, low-income people. So the discussion then fed into some issues that are very connected with the policies that we just voted on, including, as I said, Medicare for All, supporting community health clinics. But there were also some other things that people brought up that are not part of any policy that we just voted on, and I'm just going to identify those. One is the language access issues that face people when they go
Margaret,
to...
pardon me.
Yes.
Rachel Erstad from 1199, SEIU 1199 has to leave before we're going to be done with
Okay.
And she has a very important
Yes.
update for us on the Swedish Providence campaign.
Yes.
Thank you, Sybil.
Apologies for jumping ahead a little bit here. I have a concert at 8:00 p.m., so just being honest. But so there are, I think a lot of people in the room probably already know that over approximately 8,000 workers at Swedish Health Services or Swedish Medical Centers, a lot of people know it as, are standing up for their patients and their community by, right now asking the community to understand that they've been on bargaining for over 8 months and they have actually had a vote to do with the last thing that workers want to do, which is to go out on strike if necessary and if they do not get what they need to provide care for their patients. So I just wanted to, and thank you, David, for giving me this opportunity to do this. We do have a site that's up there, unitedforsafety@swedish.com, and this is an opportunity to sign a petition to hold Swedish management accountable and Providence officials accountable to do the right thing for patients in their community. We haven't seen the type of movement we need to see for staffing, for retention, for recruitment, for racial justice. Workers have talked to the community, have talked to patients, have also experienced things that should not be happening at a hospital like this. Swedish, since being acquired by Providence, which is a very big system, as I'm sure many people in the room know, the quality of care has changed, the access of care has changed, and workers are doing, I believe, a really brave thing by standing up for their community and standing up for their patients and saying, like, hey, enough is enough. We need to make sure that the care that we can provide and the care that we're able to provide is what the community deserves. So we are very excited to have this opportunity to just raise this to people's consciousness. I think a lot of people already know, like I mentioned, but signing the petition, and there likely will be updates in the future, and you may be asked to support in a variety of different ways in the future, but yeah.
Am I right, Rachel, that the next bargaining session is December 30?
Yes, you are right, David. Thank you.
And there was I just came from an action with the workers, and actually at our last meeting we had a representative from Swedish, an organizer, and there were songs sung in the neighborhood of the CEO. The fees they charge are frightful and the staffing's mean and spiteful. Tell the Providence CEO, share the dough, share the dough, share the dough.
We are a creative crew.
It was a great action, so.
I will report that back.
Yeah. And so what we can do is sign the petition.
Yes.
And possibly there will be an action coming up.
Yes, and we'll make sure that folks are aware of what the action is and what the asks are as that comes closer. But for right now, the petition is the biggest thing that folks can do tonight to stand up for people in their communities.
The
Thank you very much.
petition is in the last two newsletters too. The links right there for that one and the neighbor care.
All right, I'm going to just wrap this up with a couple more points. The folks in the small groups talked about barriers to healthcare were access to language. There were also some comments about recruitment and retention of people of color, immigrants, to staffing of the healthcare providers. And barriers to that were sufficient loans and grants. People want to see federal funding and training programs, both to provide educational opportunities and also increase the number of PAs, physician assistants, and nurse practitioners. Dental care came up, and we did deal with that in the proposals. And supporting unions and supporting increased staffing also came up in a number of small groups. So that was recognized as an issue that has to do with race and equity. And then finally, people who are the most vulnerable, people who are the most impacted, should be more involved in the legislative process. So these were things that came up in several small groups. And if people are open to it, we may do additional small groups in the future just to get at all of your best thinking about what we should be working on. And this list over here is another good list that the policy committee will be considering.
Hello, everyone. So Bevan and I have been interim co-chairs of the policy committee, which has grown quite large, and we're really excited about that. But we also wanted to let you know that it's a temporary role for us, and so we're still looking for somebody to lead that committee and also to act as secretary back to the steering committee. So if anybody in this room is interested in that, or if you know somebody at an organization that you work with, that would be great for this role. We very much appreciate getting that particular portion off of our very small organization's plate. Thank you.
All right, that's number one. I'm gonna hand it off to Marcia.
Thanks, Nathan. There's for all you early risers, tomorrow there's a chance to tune in to a live stream on Facebook of Ro Khanna's event. It is an experts discussing Medicare for All savings. Now this workshop or panel has been previously described as Medicare for All costs. But when I saw the title as Medicare for All savings, I said, wow, this is going to be different. So I think it might be worth tuning into. No doubt it will be preserved for future video watching, so if you don't wake up at 7, no. I'm sure we'll have some information on how to access the video of that later. But it's at, there's a
I wrote it up
event
there,
page.
Marcia.
Oh, do you have it?
Yeah, the
Okay.
Facebook URL is
Facebook.com/events.
and then a long
bunch of numbers. So the people that are on the panel will be Donald Berwick. He's the former head of CMS under President Obama. And he's the lead author of a cost estimate paper underlying Senator Warren's Medicare for All plan. Linda Blumberg, she's an economist and an institute fellow in the Urban Institute's Health Policy Center and lead author of a recent Medicare for All cost estimate. And Robert Poland, he's a professor of economics and co-director of the Policy Economic Research Institute, Perry, at UMass Amherst, and he's the lead author of Medicare for All cost estimate, his cost estimate. And then there's Amira Sequiera, the lead legislative advocate for National Nurses United. So this promises to be a very interesting panel tomorrow at 7 a.m. Only until 8:30 though. You could go back to bed, I suppose, if you're up for it. It's a Facebook event with Ro Khanna is sponsoring it.
Right, I was just going to say, he convened the program, Ro Khanna, the one who introduced the State-Based Universal Healthcare Act.
That's right.
Just a quick reminder that people also should go and comment on the Workgroup website to go to Washington. You can Google it, or you can go to the Healthcare Authority and click your way and leave your comments. People who showed up to speak in person weren't able to speak because there was a bomb threat and they emptied the building. But you can comment until the end of December, till December 30th. You can comment. You can watch the proceedings and comment. They would like us to comment on the proceedings and our opinion of the work that was done yesterday. But again, it's an opportunity to comment on the work that the work group is doing, and it is our job to kind of be inputting to that. So
I just have So January 13th, there is going to be a rally to kick off a campaign around taxing Amazon, 6 o'clock at the Washington Hall. So obviously for all of us who are concerned about healthcare, homelessness, affordable housing, Green New Deal, we need revenue, right? So we need to be taxing Amazon. So please come, 6 p.m., tax Amazon at Washington Hall.
And I'm remiss not to announce three things. One, Sharon Crowley says goodbye. She's from the UAW 4121. But there were two sponsor organizations that expected to be with us tonight to vote. Actually, three who could not. Janet Varon from NOLA, she said she endorses all the proposals. NARAL Pro-Choice Washington, a new sponsor of our organization, she had medical issues today and she had to stay home. She couldn't even get on the phone. And Gwen Wrench from the Retired Public Employees Council, the sponsoring organization, had to take her husband to the emergency room. And she left off notes, bless her heart, she left off notes here detailing how she supported things strongly, or priority, and so on and so on. Anyway, she would have voted for the whole package. But they weren't with us tonight, but they wanted to be.
David, go ahead, David, and then I guess, go ahead, just a second. There's a sign-on letter that has been passed around by Students for a National Health Program, the UW chapter, as well as chapters across the country, and PNHP Western Washington is also, we blasted it out last week, but it's an opportunity for healthcare professionals to sign on this letter, which is directed at your representatives to get them to sign on to national single payer, improved single payer, such as in Pramila's bill. So Washington Pop, I hope you can help spread it around.
Where is it?
Where is it?
Yeah.
I blasted it out, but I will make it available. It's a very good letter.
I want to kind of piggyback on something that Taya was saying to you about making comments on the work group. The thing that I noted that really disturbed me was that they were talking about evaluating three possible plans, and having them actuarialized as possible programs for them to adopt or suggest or endorse or whatever. But they didn't mention 5222 at all. And I have to say that was what started this whole thing, was 5222. And so I want to be sure that if you do make a comment, that you include that in your comments, because that bothered me a lot. That's really based on the Washington Health Security Trust Bill. It was modified and rewritten. It was put through the paces by both Emily Randall and Nicole Macri's staff. And so it really is the thing that we need to have them evaluated at. And when they did this, I think it was almost 10 years ago, maybe I'm wrong, for the WIST bill, they didn't use the WIST bill. They went up and chose the Canadian bill. So the WIST bill has never actually had an actuarial evaluation. And so I think we really need to have that. If that's a possibility in our state, then we need to know how it's going to work out. Thank you.
The New England Journal of Medicine last week, their December 5th issue, has an article that's called the Shattuck Lecture. I'm not sure how long they've existed, but I know there was one in June of 1957, so they've been around for a while. But in this case, the author was a recent head of Mayo Clinic. His name is difficult to forget because it's Dr. Noseworthy, as in nose. You can't forget that name. But the reason I'm bringing it up is that he mentioned that a successful healthcare system must be built around preserving the patient-physician relationship. And the reason he's bringing it up is because that is being totally submerged in our current healthcare system, as we're seeing in this Providence Swedish mess that goes back to Johnny Delashaw. It's just gone. But it's something for us all to remember. Physicians have all taken an oath to put their patients' interests ahead of their own. If we put the patient-physician relationship at the center, that puts the patient's interests first. And we need to, it's kind of a reminder of all of us that we need to remember that as we look at ways to change the healthcare system in America.
Along the same lines of the actuarial person, they said that they have to have one very different model from two similar models. Mm-hmm. And that's just screaming WIST and 5222 to me. And that's a lot of money that went into those. Like Catherine said, at the grassroots level, just to get that Friedman study was $20,000 or some dollars. Mm-hmm. So couldn't those be the similar models? Also, I have with me almost at all times Pramila Jayapal's Add Your Name to Support Medicare for All. And I'll bring it with me every time, but if you're near me and you want to sign it, I'd love that. Thank you.
And Pramila Jayapal sent us a communication today, which I don't want, oh, here it is, for our meeting. Her district director, Rachel Bergson, who wanted to be here but could not. And she just wanted to say that Pramila applauded the passage of improved H.R. 3, the Elijah E. Cummings Lower Drug Costs Now Act, and she had worked over many months with Speaker Pelosi to expand the scope of the bill and to add amendment after amendment to make it more progressive and more consumer friendly. And they negotiated a lot of critical improvements. So I just wanted to say that that's something that just happened, that Pramila Jayapal had her hands on all over it, and they wanted us to know.
Good.
All right. And I think that about does it. Thank you very much, all of you, for coming and for your participation and for your work. Be well. Happy holidays. We're going to see you in the new year. Happy holidays.